Now it works. Okay. Good morning, everybody. I want to welcome you in our both names to this second session on the new ASMBS Ifso guidelines. The headliner for this session is the high-risk patient, cirrhosis class 5 obesity. This is the new definition of BMI above 60, heart and renal failure. Our first lecture will be given by Giacomo Piatto from Italy, a systematic review for the new guidelines under this aspect. Please, Giacomo.
Good morning, everyone. Thanks, Ifso, and all the present for this wonderful occasion. So, I have nothing to disclose, and this is my case mix disclosure. So, we'll know that 30 years after the first consensus statement on bariatric surgery, last year, Ifso and the Asmbs joined their forces to provide some new indications and some major updates on bariatric and metabolic surgery. Especially, they identified 3 categories of high-risk patients that were BMI greater than 60, cirrhotic patients, and patients with heart failure. And they stated that carefully selected individuals considered higher risk for general surgery may benefit from metabolic and bariatric surgery. So our task was to perform a systematic review of the literature according to the preferred reporting item for systematic review and meta-analysis to methodologically support these new indications. The first step was to define which were the exclusion criteria, and then we followed the flow chart to select the papers. Concerning BMI greater than 60, we see that Ifso and the Asmbs say that metabolic and bariatric surgery should be considered as the preferred method to achieve clinically significant weight loss in patients with extreme BMI. So we started with our search strategy that was shared among all the researchers of the team, and then we identified more than 600 papers. After the selection and exclusion process, we identified 47 papers. There were no randomized control trial. 25 were comparative between different classes of obesity. 9 compared different surgical techniques. 12 studies were focused on safety and feasibility with a 30 days follow-up, and 35 included the medium to long-term results. The population was composed of 8,400 patients with a mean follow-up of 28 months and a mean preoperative BMI of 66.6. Mean percentage of excess of BMI loss was 51.5%, and with a mean delta BMI of 21, that is relatively high. But we're speaking, of course, of extreme obesity. Comorbidity resolution as reported, so good enough. And overall early complications was about 5%, with an overall reoperation rate of 3%. Overall mortality of 0.16%. Interestingly, there were more than 2,000 patients with BMI greater than 70, with a mortality of 0.4 and a reoperation rate of 3%. So in conclusion, the systematic review supported Ifso and the Asmbs indications for metabolic and bariatric surgery in people with BMI greater than 60, and we can recommend that metabolic and bariatric surgery is safe and effective in patients with BMI greater than 60 and appears to be safe even in patients with BMI greater than 70. Concerning cirrhosis, we see that metabolic and bariatric surgery is associated with good benefits in compensated cirrhosis, but of course a careful selection of patients is required. So even in this case, we shared the search strategy, and we started with almost 7,000 papers. At the end of the selection process, 15 papers were identified. Even in this case, there were no randomized control trials. And interestingly, there were 3 comparative studies comparing metabolic and bariatric surgery in compensated versus decompensated cirrhosis. Population was composed of 7,600 patients with a mean follow-up of 27 months and a mean BMI of 44. Good results in terms of weight loss. Interestingly, early mortality and early complication was significantly low in compensated versus decompensated cirrhosis, and there were some controversies about liver function and mild effects on metabolic and bariatric surgery. Even in this case, we can conclude that the systematic review support the indications for metabolic and bariatric surgery in cirrhotic patients. Of course, it's safe and effective in compensated cirrhosis, and there must be always a risk assessment, and metabolic and bariatric surgery in this category should be performed only in high-volume centers. We have seen that sleeve gastrectomy might be associated with lower liver decompensation when compared to Roux-en-Y gastric bypass. For heart failure, we see that metabolic and bariatric surgery can be a useful adjunct to treatment in patients with obesity and heart failure. This is what Ifso and the Asmbs state, with a significant improvement of cardiac function. In this case, we shared the search strategy among all the researchers, and we started with more than 6,500 papers, but we concluded with 19 papers. Even in this case, there were no randomized controlled trials, all retrospective studies. There were 5 matched core studies, 2 with the propensity score, that is an experimental method that provides that helps to create a population to be compared to reduce the selection bias. We see that there was a huge heterogeneity among the papers. The population resulted on 8,700 patients with a mean follow-up of 40 months, mean preoperative BMI of 44.5. Mean postoperative weight loss was good, and we see that early mortality was 0.15%, up to 10% when the population was not propensity matched. This is very important. Cardiopulmonary early complication was obviously higher after metabolic and bariatric surgery in heart disease, heart failure patients when compared to those not operated. But cardiopulmonary late complications were low after metabolic and bariatric surgery in heart disease, heart failure patient compared to those not operated. In particular, major adverse cardiovascular events were 11.5% versus 19%. Interestingly, concerning population that was involved in bridge to transplant, we see that after metabolic and bariatric surgery, 76% of patients had an increase of at least 10% of the left ventricular ejection fraction. 8 patients were removed from transplant list, and 9% patients were had the left ventricular assist device removed because of an improvement of cardiac function. So even in this case, our data support Ifso and the Asmbs indications for patients with heart failure. So we can see that in this category, metabolic and bariatric surgery is safe and effective, and reduce in the medium to long term major cardiovascular events, and also improve chances of receiving heart transplantation up to be removed from transplant list thanks to cardiac function improvement. So this is very important. One last slide on renal failure. We see that Ifso and the Asmbs state that more than 50% of patients with end-stage renal disease and morbid obesity are able to be listed for kidney transplant. This item was not included in a single systematic review, but was part of the Bridge to Transplant systematic review. So there were 17 papers concerning metabolic and bariatric surgery before kidney transplant. We see that mortality 1 year after metabolic and bariatric surgery was relatively high, but this included people with end-stage kidney disease. but we see that 59% were successfully listed for transplantation, and 33% of all the population was successfully transplanted. And this is very interesting. Mortality in wait-listed patients, so patients that achieved enough weight loss to enter the wait list for transplant, had a mortality of 1.8% a year after metabolic and bariatric surgery, compared to a four-fold higher percent of mortality in people without metabolic and bariatric surgery. So we see that metabolic and bariatric surgery is associated with acceptable higher risk of complication in patients with renal failure, and increases the possibility of being listed for kidney transplantation in more than 50% of patients. Thanks for your attention.
Thank you very much. It's a pleasure to be here. I'm Pasquale Peroni Filardi. I'm the president of the Italian Society of Cardiology, and very much pleased to be part of this meeting and learn from the surgical colleagues. Now we go deep into the fields that were touched by Dr. Piatto, and it's my privilege to invite to the podium Professor Aminian. She's a He's a professor of surgery at the Cleveland Clinic, and it's a privilege for us to listen from your talk. We know very well your publication in JAMA New England, and so we are eager to listen from you about the liver cirrhosis, when to operate or better not to operate, the question. Please.
Thank you. Thanks for kind introduction. Good morning, everybody. In the next 10 minutes, I'm going to talk to you about the role of bariatric surgery or metabolic surgery in patients with NASH and NASH cirrhosis. Here's my disclosure, nothing directly relevant to this talk. So we know that NASH is hepatic manifestation of metabolic disease and is strongly linked with the cardiovascular disease. Obesity is the main pathophysiologic driver of NASH. We know that diagnosis and management of NASH are challenging. There is no approved treatment, medical treatment for NASH, and there is no therapy that can reduce the risk of serious cardiovascular or liver adverse outcomes in patients with NASH. In terms of the NASH progression in people with obesity, so we have fat accumulation everywhere, including into the liver, and over the time, with having that fat accumulation for years, then inflammation comes and cell damage occurs, which is called NASH. And on top of that, gradually scar tissue forms, which is called fibrosis. Fibrosis is getting worse over time, start from F0 to F4, different stages of the fibrosis. F0 can progress to F1, over the years can progress to F2. F3 is the bridging fibrosis, and then F4, which is the cirrhosis. And then cirrhosis, again, going to progress slowly over the years from compensated cirrhosis to decompensated cirrhosis. Then hepatocellular carcinoma may occur, liver failure, and death. So that course may take 20, 30, 40 years. And we will see how bariatric surgery can stop that progression or reverse the progression. So in terms of the effect of the surgery on regression of liver damage. Let's look at our data from Cleveland Clinic. So we had about 130 patients who had repeat liver biopsy on a median of 2 years after enrollment. And as you see here, let's look at the second column, NASH resolution. So in the second liver biopsy, 68% of patients after bariatric surgery had complete NASH resolution versus 22% in the control group. In the column 3, you see the fibrosis improvement, 64% after the surgery versus 21%. And let's look at the combination of both, complete NASH resolution versus fibrosis improvement. Almost half of the patients who had liver fibrosis and NASH at baseline had complete resolution of NASH and improvement in their fibrosis 2 years after bariatric surgery versus 12% in the medical arm. Fibrosis progression 25% versus 5%. So that was a cohort study. We have a randomized clinical trial that support that finding, and that was the BRAVE clinical trial from Italy that was published in Lancet a few months ago. In that RCT, almost 300 patients with NASH were randomized to 3 groups: lifestyle modification, gastric bypass, and sleeve gastrectomy. And as you see here, around 50–55% of patients after surgery had NASH resolution versus about 16% after medical therapy. And in terms of the fibrosis improvement, again, around 40% after a surgical procedure versus 20%. And both of these comparisons were highly significant. So there was no difference between the gastric bypass and sleeve gastrectomy in terms of improvement in NASH or liver fibrosis. So without no doubt, the surgery or surgically induced weight loss can reverse the progression of NASH and liver fibrosis. How about the hard clinical endpoints? So as I briefly explained, NASH is strongly linked with cardiovascular outcomes, adverse outcomes. And actually, heart attack, heart failure, cardiovascular death is the major cause of mortality and morbidity in patients with NASH. So to answer this question, to see if bariatric surgery or metabolic surgery can decrease the risk of major adverse cardiovascular outcomes, we looked at our cohort from Cleveland Clinic, which were followed over the course of 20 years. In this study, which was called Splendor, published a couple of years ago in JAMA, we had 650 patients who underwent gastric bypass and sleeve gastrectomy. All patients had NASH and liver fibrosis at their baseline liver biopsy, and they were carefully matched to over 500 patients who received usual care for their NASH and liver fibrosis. So we had 2 pre-specified endpoints. One is MALO, which is progression of NASH and liver fibrosis to major adverse liver outcomes, including progression to cirrhosis or development of hepatocellular carcinoma, need for liver transplant or liver-related death. And the other one was MACE, or major adverse cardiovascular event, which was defined as composite of heart attack, stroke, heart failure, or cardiovascular mortality. So as you see here, both groups were carefully matched at baseline. So at baseline, 50% had stage 1 fibrosis, 29% in each group had a stage 2 liver fibrosis, and 20% had a stage 3. So we excluded patients with cirrhosis at baseline. So obviously, surgical patients lost a lot of weight. Over the course of 10 years, they were able to keep it off over the course of 10 years. And that led to almost 88% reduction in risk of progression of NASH and fibrosis to cirrhosis. So over the course of 10 years, 2% in the surgical group progressed toward the cirrhosis versus 9.6% in the control group. Ladies and gentlemen, this is very, very large effect size, 88% reduction in risk of progression of NASH toward the cirrhosis. How about impact of surgery on risk reduction for MACE? Over the course of 10 years, 8% in the surgical group developed MACE, heart attack, heart failure, stroke, cardiovascular death versus 15% in the control group. So again, surgery could decrease the risk of developing MACE in patients with NASH and fibrosis by 70%. So I'm going to talk to you about the indications of bariatric surgery in NASH briefly. So based on the compelling data that we have, now we can say that in patients with obesity and NASH with fibrosis of fibrosis stages between F0 to F3, surgery is highly recommended because it can reverse the histopathology of the NASH, and it can decrease the risk of major adverse outcomes in those patients. How about in patients with obesity and F4 or cirrhosis? So as the previous speaker reviewed the literature, in patients with cirrhosis, if they have compensated cirrhosis without portal hypertension, bariatric surgery can still be considered. So again, in terms of the NASH progression. So we have normal liver, simple steatosis, then inflammation, fibrosis compensated cirrhosis, decompensated, and then liver failure. So in the earliest stage of the disease, so we have a window that we can intervene. This is a very long window of 10, 20, 30 years because NASH is a slowly progressive disease. So if we can intervene in early course of the disease, even if the patient has NASH, even if the patient has fibrosis, even if the patient has compensated cirrhosis, we can intervene and reverse the course of the disease. If the patient has progressed to decompensated cirrhosis, it's too late. So one other point here is that in patients with compensated cirrhosis, we need to rule out portal hypertension. Because if the patient has portal hypertension, you don't want to fire the stapler on the stomach. That may cause profuse bleeding and can be life-threatening. So if the pre-op workup shows that it's suspected for cirrhosis, if the patient had liver biopsy before surgery and shows cirrhosis, or if the patient has low platelet count, which can be indicative of portal hypertension, or fibroscan, or non-invasive test that is suspected for cirrhosis. In our institute, we do the endoscopy and liver vascular ultrasound to rule out the portal hypertension. If no portal hypertension, we're gonna proceed with the surgery. If portal hypertension, if the patient has if the patient meets the other criteria for surgery, we're going to ask our interventional radiologist team to place a TIPS, transjugular intrahepatic portosystemic shunt, to lower the portal pressure. And after placement of TIPS, we're going to wait a couple months. We're going to repeat the liver vascular ultrasound to make sure that portal hypertension is controlled, and then we're going to schedule the patient to undergo surgery. So, to summarize, I listed a few contraindications of bariatric surgery in setting of NASH and NASH cirrhosis. First off, in patients with decompensated cirrhosis, that is too late to do the surgery. These patients would require liver transplant usually in the next few weeks or few months. And decompensated cirrhosis, by definition, is the patient who has ascites, hepatic encephalopathy, or variceal bleeding. Patient with portal hypertension is a relative contraindication for surgery that can be managed by placement of TIPS to lower the portal pressure and then reassess the patient to check the eligibility criteria for surgery. In patients with MELD score over 15, again, that's a relative contraindication. MELD score over 15, those patients are very close to be listed for a transplant and for the liver transplant, and those usually have the other complications of the liver disease, so those are usually sick patients, and if the patient has severe coagulopathy. So in terms of the bariatric procedure selection in those patients, in NASH with F1 to F3, our bariatric procedures are appropriate options. As we saw in the BRAVES trial, both gastric bypass and sleeve gastrectomy could decrease the risk of NASH progression. So both sleeve and gastric bypass are good choices. In NASH with compensated cirrhosis, F4, probably a sleeve gastrectomy would be a better choice over the bypass procedures because many of those patients would require liver transplant in the future, and we know that patients who undergo liver transplant, they usually need to undergo ERCP, multiple biliary access, biliary tree access in future. So a sleeve gastrectomy can preserve access to the duodenum and the biliary tree. There is less risk with the immunosuppressive medication absorption after a sleeve. And then if the patient has already a root construction after the bypass or the duodenal sewage, creating another route to do the hepaticojejunostomy after transplant can be challenging. So from technical standpoint, then a sleeve would make the future transplant easier. So in summary, metabolic surgery is safe, effective treatment for obesity and NASH, especially in patients with F1 and F3. Also, it can be considered in selected compensated F4 patients without portal hypertension. And if we intervene with the surgery in that long window, opportunity window that we have, that can lead to NASH resolution in over half of the patients, lowering the risk of MACE and MALO in about 75% of patients. And we need to rule out portal hypertension in patients with suspected cirrhosis before surgery. And if there is a portal hypertension, before going to the OR and firing a staple on the stomach, we need to consider TIPS placement. Thank you very much.
Thank you very much. We have only time for one question, very brief question.
Ali, thank you very much for an excellent presentation, as usual. I have a question about procedure selection. I noticed that in both the BRAVES trial and in your trial, only sleeve and bypass were looked at. So two-part question. Is there a way surgeons could do other procedures like one anastomosis gastric bypass, Saudi or DS? And the second question is, if you go into surgery and you find unrecognized cirrhosis, and you were planning, let's say, a one anastomosis or DS, should you change the procedure? Should you go ahead?
So in terms of the data that we have, I mean, the best data that we have is comparison of the sleeve versus gastric bypass, and both are equally effective in terms of changing the liver-related outcomes. So we don't have data on the other procedures, but I would expect we're going to have very similar outcome with the other procedures, unless we make a very long BP limb and do very extensive malabsorptive procedures that can further cause the liver damage. So those type of procedures probably wouldn't be recommended in those situations. In terms of going to the OR without having any idea and then see a cirrhotic liver, and the plan is to do the gastric bypass, probably that's not going to happen. We get some idea beforehand that the patient has advanced liver disease. So if I go to the OR, no idea before surgery, and see an engorged vessel, sign of portal hypertension, I'm going to abort the surgery. I'm going to do liver biopsy. I'm going to abort the surgery. If I go in and there is no, liver is cirrhotic, but there is no portal hypertension, there is no engorged vessel, I do the scope in the OR, no esophageal varices, and the plan was to do the bypass. I didn't talk to the patient about the sleeve, then I probably again abort, I'm going to do biopsy, abort the surgery. If I had spoken with the patient about the sleeve before, then I probably gonna proceed with the sleeve. So I try not to do the bypass if there is a cirrhosis. The other point is that the morphology is not accurate. So you may see it's cirrhotic, but we do the biopsy, it's F3, it's not F4. And then you may come back and do the bypass.
Thank you very much. We really have to stay in time for all the speakers. There are still free seats on the front for you in the back. Take your seats and we go on with the program.
Perfect. So next, it's my pleasure and privilege to introduce Shanu Kathari from Prisma in South Carolina. Shanu is the past president of Asmbs, and he's going to speak to us about metabolic and bariatric surgery in BMI over 60, operative strategy, and perioperative risk reduction.
Thank you so much for that kind introduction, Dr. Minian, Dr. Prager, and others. Thank you so much for the privilege of the podium and to be able to see such a full room on such an important topic as well. These are my disclosures, none of which should have anything to do with this talk. I also want to disclose that I am forever indebted to the other co-authors on this significant contribution to our field, not only to our field, but also, I think, the most significant contribution in the last 30 years to update our guidelines and to update our relationship between ASMBS and Ifso, which was a profound collaborative event. I think when you think about mortality or BMI over 60 versus other patient populations, these are the things that come to mind, and these are the things that I'm going to briefly review for us this morning. So here's a single surgeon series paper and 213 patients looking at BMI over 60. You can see the mean BMI of 67 versus 48. No difference in major or minor complications in that particular surgeon's series. No difference in total weight loss, but difference in excess weight loss, which we know because the BMI is fundamentally different, and excess weight loss is a function of your starting weight. So we've moved away from that, but you can see still good weight loss overall between the two groups. So his conclusion was similar complications and could be done safely. This is another series looking at different procedures as opposed to a single surgeon with single procedure, looking at again, BMI 60 and above versus less than 60 with the different variables as listed here. Large series, over 3,600 patients looking at these outcomes. And we showed, again, the usual types of comorbid conditions, higher prevalence and the higher BMI as one would expect. And again, the difference in this one was a longer operative time for patients with BMI greater than 60. Gastric bypass patients also had longer length of stay in this particular publication, and more were likely to be discharged to a chronic care facility based on mobility issues. So they concluded that it was safe. There was no difference in that particular mortality between these two groups, but longer length of stay and more likely to be discharged to a chronic care facility. Dr. Shikora's group also looked at this. 95 patients compared to the 1,300 with less than BMI 60. You can see the mean BMIs and the difference between the two respective cohorts here. Operative time was longer. Estimated blood loss and length of stay and overall complications was not different in their hands. Mortality was no different either. In fact, the few that they had were in the under BMI 60 group. Interestingly, again, when they looked at their overall complications, no difference, but the leak rate was different, but it was actually higher in the lower BMI group in their particular series. But overall, no difference in complications, no difference in mortality. Another group looking at this, single surgeon series. Again, the difference between the BMIs, highly different as one would expect comparing these groups. But again, no difference in complications, both major or minor. And their conclusion was, once again, can be done safely in this cohort of patients. Looking at this study, looking at a group from Stanford looked at their outcomes as well, breaking them down into the 3 different cohorts of BMI as listed here. They also looked at anesthetic times and total operating room time and how long emergence and induction with anesthesia colleagues as well. When they looked at the 3 groups, as you could expect, higher ASA groups in the larger patient population, and they looked at the patients with a BMI over 60, and they did have longer operative times, longer times for induction, and emergent from anesthesia as well. This is just another way of graphically showing that it seemed to be somewhat linear associated with the BMI on induction time, emergence time, and total OR time as well. So again, they concluded that it did take longer anesthetic induction and emergence in this patient, and ultimately that resulted in more total OR time as well. Another area to look at is psychosocial factors in this patient population. Again, from our colleagues at the Cleveland Clinic, looked at a large series, Leslie Heinberg's group, looking at a variety of patients undergoing pre-surgical psychological evaluation. And interestingly, what they found when they compared the patients with the BMI over 60 to those without, you can see the things here that they had a higher prevalence of: binge eating, low positive emotions, ideas of persecution, and dysfunctional negative emotions. And they also showed this group had a higher prevalence of, sadly, of higher incidence of sexual abuse and others as listed there as well. So they concluded that patients with a BMI over 60 are a more psychiatrically vulnerable group, something that we should all be aware of in our practices. Enhanced recovery, many of us all do some form of this now. This is becoming more standard. They looked at time to ambulate in their ERAS protocol for patients based on their different clinically severe obese groups. The other reason I added this paper in here is, in speaking with Dr. Shikora and others, these are terms we need to get away from. This is not, we've made a lot of strides as why we're having this discussion here, but we've also made strides in our understanding of first-person language, and the terms super obese, super obese, and things of that nature need to be abandoned, and we need to, we're going to be working on that with both our respective journals in terms of making sure the language is appropriate moving forward. But nevertheless, time to ambulation with their particular ERAS protocol that they used, which is as listed here. Again, we all have many of our intra-op as well as post-operative pathways that we use. This was theirs that they use, which is very evidence-based as well. And in general, the number in this study, even though this wasn't the primary goal, was in general, the higher the BMI, the higher the complications. So the literature is a bit mixed when it comes to that. But when they looked at it, breaking down the different population, as one would expect, as the higher the BMI trended, the ratio of more sleeve gastrectomies then took place compared to gastric bypass. And what they found was, in these different cohorts, overall time to walking with support was more prevalent, as one would expect, higher BMI, more joint pain, more need for assisting with ambulation. And when they broke it down from time to ambulate, overall, the higher the BMI, it was more minutes till they began ambulating, and discharge to readiness took longer for that patient to be ready to be discharged to home as well. So in conclusion, patients do have, in general, longer operative times. Takes longer for emergence and induction of anesthetic. They're a psychologically more vulnerable group to be aware of. They may need a longer, more frequent use of the ICU. Takes longer to ambulate. Depending on in your hands or not, they may or may not be at increased risk of complications. All studies show similar mortality. So obviously we must have careful selection of patients and matching the correct patient to the right procedure, as Dr. Midian so well put it in his last talk. So again, going back to the guidelines, the whole reason we are here today in this session, what was our conclusion? That there is no consensus regarding the best procedure, but the efficacy and safety of metabolic surgery has been demonstrated in this population. And at the end of the day, we shouldn't discriminate on our patients based on their BMI. They have much to benefit as well, and it should be the preferred method to achieve clinically significant weight loss in patients with extreme BMI. Thank you very much.
Thank you.
Thank you very much, Shanu. We have time for 2 questions. Please, identify yourself, go to the mic. Otherwise, we cannot hear you. Activate the mic, please, technicians. Try it again. Okay, come here.
Thank you for this nice talk. I'm Mr. Al-Asadi, one of the bariatric consultant surgeons from UK, London. My question is for this group of people. Do you have any conclusions that at some point we need to do some genetic testing for them, or any guidelines depending on the number of BMI or something? Thank you.
Yeah, thank you for that question. I don't have any personal experience or thoughts around genetic testing on that patient population. I am excited to think, and we may learn more as we learn more from Drs. Kaplan and others around anti-obesity medications and things. What I want to know is if we can get to the point where we can use some of these GLP-1 analogs as predictors of responders or non-responders to surgery. I think that's where I think the next frontier of surgery is. If you did not respond to GLP-1 analog, are you going to respond to a gastric bypass? Or I think that's the next wave of research that I'd love to see. Is it a scattergram, no correlation, or can we, because one thing we haven't been able to do is predict success by whatever metric you want to call it, weight loss, comorbid reduction, after the same surgeries. And so I think that's where I'd like to see the next frontier of research, and hopefully internationally with our Ifso colleagues, we can do that in a multi-center fashion.
Thank you very much, Shanu. We go on in the program. It's my privilege and honor to announce our next speaker, Professor Lee Kaplan, professor at Harvard Medical School. He's a leader in the field of obesity. He published more than 150 papers in New England, Nature, Nature Medicine, and his research mainly focused on the fundamentals of energy metabolism, and he was very helpful this year at the Consensus Conference with his real, very focus on language and definitions. Lee, the stage is yours.
Thank you very much. Can I be heard out there? Yes or no? Good. I've changed the title of my talk just a little bit because I want to talk about it in a positive sense. I do like the heartbroken title, but I'm going to talk about treating obesity to promote heart health. These are my disclosures. None of them are directly relevant to today's talk. So the cardiac complications of obesity are several-fold, and they're listed here, including atherosclerotic cardiovascular disease, which we have been focusing most of attention on over the last several years, heart failure with reduced ejection fraction, that is systolic heart failure, atrial fibrillation, right heart failure from lung disease and sleep apnea, and heart failure with preserved ejection fraction, which is often called diastolic heart failure, previously called heart failure from either diastolic dysfunction or from left ventricular hypertrophy. And this is the type of heart failure that is most common and most associated specifically with obesity. But all of these disorders are associated with obesity. So the question first off is, does obesity treatment improve any or all of these complications? And does obesity treatment prevent any or all of these complications? And finally, does any beneficial obesity treatment depend on the actual amount of weight loss, or are the effects primarily independent of the weight loss with various treatments? So in a retrospective case control study that Ali did and published 4 years ago, what you see here is that overall, looking at a primary endpoint of 3-point major adverse cardiovascular events, MACE, and you'll hear the word MACE throughout my talk, including non-fatal myocardial infarction or non-fatal stroke or cardiovascular death, you can see a substantial improvement with bariatric or metabolic surgery as compared to the non-surgical controls. Similarly, if you look at a secondary endpoint in his study, 6-point MACE, which includes those three, well, actually it includes cardiovascular, coronary artery events, cerebrovascular events, which are similar to two of the ones in the 3-point MACE, all cause mortality, not cardiovascular mortality, but in addition, two of the other cardiac complications of obesity, heart failure, atrial fibrillation, as well as nephropathy, you can see once again that there is a benefit in this study for patients who have metabolic surgery. Now, with respect specifically to heart failure, and this is all-cause heart failure, so this doesn't differentiate specifically of the three types of heart failure that I indicated earlier, you can see a dramatic improvement in heart failure, both HFrEF and HFpEF, reduced and preserved ejection fraction with surgery as compared to non-surgical controls. If you look at atrial fibrillation, as Ali did in this study, well, you can see once again that metabolic surgery demonstrated a benefit for heart function as evidenced in this dysrhythmia. Now, let me turn over to some newer data, and these are data from the newer medications. So as you well know, throughout this meeting and with all the lay and press popularity of this, that we're entering a new generation of anti-obesity medications that I call Generation 3. Generation 1 was where we lived for many, many decades. Generation 2 was the introduction of the better-than lifestyle medications about a decade ago. And Generation 3 starts with semaglutide at 2.4 milligrams per week and extends to tirzepatide and all of the other drugs listed on the far right of this slide. Well, it turns out that semaglutide does induce sustained weight loss of about 15 to 17% in patients without type 2 diabetes and about 10 to 12% in patients with type 2 diabetes. What are the effects on cardiac function? Well, in the SELECT trial, the data were just announced but not yet published 2 weeks ago, looked at 17,600 patients with high risk of coronary artery disease, cardiovascular disease, including coronary artery disease and stroke. They were all over 45 years old. They all had obesity. None of them had diabetes. It's critical to emphasize that none of them had diabetes. This was an event-driven trial which just finished earlier this year, and that the primary outcome of the trial was time to first occurrence after the onset of the study of three-point MACE, the same three-point MACE that we just talked about in Ali's study, non-fatal myocardial infarction, non-fatal stroke, or cardiovascular death. This is a more stringent outcome because it only looks at the three most severe cardiovascular deaths without some of the other issues that I was just talking about. The top line outcome was that subjects treated with semaglutide had a 20% risk reduction, or not a risk reduction, 20% reduction in MACE, major cardiovascular events. I just want to compare that to the previous studies of other medications in patients with diabetes. And in the case of statins, it's about a 25% reduction. In the case of SGLT2 inhibitors, it's about a 13% reduction. In the case of these drugs, like semaglutide, in patients with diabetes, it's about a 14% reduction. And here in patients with obesity, it was a 20% reduction. Now, this is only the first shot across the bow. This is the first prospective randomized controlled trial of any obesity therapy that demonstrates a reduction in major adverse cardiovascular events. The very first one, it won't be the last one, and we look forward to more as I talk about. But I want to turn my attention now to another aspect of cardiovascular disease, which is heart failure with preserved ejection fraction. And this was a trial that was published in the New England Journal of Medicine on Saturday, just this past Saturday, which was the STEP-HFpEF trial, which compared patients receiving 2.4 milligrams per week of the same drug, semaglutide, with placebo. And you can see here that the difference in the weight from this, about a 13% weight loss with the semaglutide in this group. These patients had, some of them had diabetes, some of them did not have diabetes. If you look at a subjective patient-reported outcome, which is through the Kansas City Cardiomyopathy Questionnaire Clinical Summary Score, you can see that the overall function of these patients in terms of quality of life was substantially better on semaglutide as compared to placebo. Looking more objectively at a 6-minute walk test, you can see here that there was a dramatic increase in the distance that these patients could walk in 6 minutes on semaglutide versus placebo after 1 year of therapy. And finally, if you look at overall outcomes for this trial, you can see all of the measures, including objective measures and patient-reported outcomes, improved by 50%, nearly 50%, with the treatment with semaglutide. Death went down by about 25%, and the number of active heart failure events during the study went to 0 in the patients who were on semaglutide compared to 3.3% during the study in the patients who were on placebo. So in conclusion then, we know that both metabolic surgery and Generation 3 anti-obesity medications have been shown to reduce major adverse cardiovascular events. Surgery via multiple retrospective case-controlled studies in patients with obesity and diabetes, and I mentioned that by Dr. Aminian because it's the best of those studies. Semaglutide has been shown now by RCTs both in patients with obesity in a with diabetes in a previous study, and with obesity without diabetes for the first time in the study that I showed you. Both metabolic surgery and Generation 3 anti-obesity medications have been shown to reduce heart failure. Surgery in an all-cause heart failure study, which was a case-control study with patients with obesity and diabetes, and semaglutide in the HFpEF study, also in patients with obesity and diabetes, with or without diabetes, in a randomized controlled trial. Metabolic surgery has been shown to reduce atrial fibrillation via a retrospective case-controlled study, as I've shown. It has not been shown excuse me, with medications as of yet. So I would conclude then that treating obesity is an effective and valuable means of promoting heart health, whether you do it surgically or now medically or in the future through a combination of both. Thank you very much.
Thank you very much for this very nice presentation. I have a few comments and a question for you, and I understand it's only a speculative question. We will be learning in couple weeks, in 4 weeks at Philadelphia, the detail of the data of the SELECT trial that will be presented at the American Heart Association. But these data are impressive, and they bring this new class of drugs, as for the SGLT2 class of drugs, into the field of non-diabetic patients, as you were mentioning, patients with obesity without diabetes. Can you speculate on the mechanism of benefits for cardiovascular risk reduction? It's pretty much linked, in your opinion, to weight loss, or there are peculiar mechanisms from a GLP-1 agonist that they be independent from weight loss to give this risk reduction?
Yeah. So that's a great question. And my best answer is that we don't know. Think of all the work that we and others have done looking at the effect of metabolic surgery on diabetes and all the debates that still exist between are those effects due to weight loss or are those effects independent of weight loss? I would argue it's both, but others can argue differently. I think with the SELECT trial, we're not going to know the answer, although there are exploratory outcomes that will compare the degree of weight loss with the improvement. Those studies will be done. They won't be shown in November, but they'll be done in the future.
Yes.
In addition, there's, just to answer the question that was asked of Dr. Qatari, the DNA has been saved, as have samples for biomarkers in all 17,000 patients in the study, so we'll learn a lot more about prediction as well. But the one thing I want to answer about the mechanism vis-a-vis the HFpEF study, which is a different kind of a study. There, a second paper was published just 2 days ago on Monday in Nature Medicine that showed that there's a good correlation between the degree of weight loss in the same study that I showed the major data from. There's a good correlation between the degree of weight loss and the improvement in the outcomes that were measured in the HFpEF study. So there we would say that the weight loss is clearly contributing substantially. I suspect it is in the other as well, but we don't know.
Thank you very much. Well, for the sake of time, we go ahead with the next presentation from Professor Proger from Austria, and metabolic bariatric surgery as a bridge to heart transplantation, the results, limitation, and the risk and the perspectives. Please.
Dear friends and colleagues, we go back to metabolic bariatric surgery, a very specific topic. MBS is a bridge to heart transplantations, and I'll chase you a little bit through the literature and a little bit about our own results. My disclosures, my case mix slide. So you're well aware that obesity and especially class 2 obesity is in many countries considered a relative contraindication against cardiac transplantation. So obesity itself hinders the access to this very effective treatment, saving life of people with heart failure. When we look at the literature, there are not many data on patients with low left ventricular ejection fraction. I brought you this one, published a few years ago, and you see 7 patients with an LVF below 25%, and the outcome after metabolic surgery with a weight loss of approximately 13 BMI points is an increase up to 30%, and remarkably, you see 4 out of these 7 patients were listed, 2 out of these 4 that were listed underwent heart transplantation, and 3 even improved so much that they didn't need any operation more. So this is in line with the results that Professor Kaplan showed you. The conclusion is metabolic surgery is, by a successful weight reduction, enabling a successful heart transplantation, and in some patients they improve so much that you even can avoid the heart transplantation because the cardiac function improves that much. Is there a limitation? Yes. in the setting of the operation, there is a higher risk for acute cardiac decompensation, and this is also well known from the literature that heart failure is associated with a 7-fold increase in the perioperative mortality during metabolic surgery. So we must be very cautious in these patients with a very low left ventricular ejection fraction. What is about metabolic surgery as a bridge to heart transplantation for those patients who are on a left ventricular assisted device? This is an artificial heart pump, and this is especially true for patients with a BMI above 35. They are on the LVAD for years, and this is a real problem because they don't get listed and of course experience, number one, the complications of the LVAD, which is mainly thrombotic complications, but also chronic line infections, arrhythmias and others. And even although they know that they will be listed, if they lose weight, they are not able to lose enough weight to get listed. In this paper, 12 patients, and you see 8 out of 12 reached the target BMI of less than 35. 4 out of 12 underwent heart transplantations, and 2 further were listed for heart transplantation. Again, BMI reduction, 10 points, very typical for sleeve gastrectomy. Are there any downsides? Yes. These patients are at very high risk for bleeding. One was revised due to bleeding, one was conservative managed, and another one had a readmission. In Vienna, we operated on 7 patients on LVAD, and we had 2 bleeding complications. One was at the trocar site, because at that time, the non-cutting trocars were not available, and we used a cutting trocar for a 15-millimeter trocar, and I inadvertently punctured a small artery, and that patient was bleeding, not coagulating, and we had to go back again. And the second patient also with a bleeding complication. Of course, you are in a very difficult situation. They are under fully anticoagulation, those LVAD patients, and this is maybe some limitation for these patients. You can do these operations, of course, only in a hospital where you have cardiac surgery at cardiac transplant unit. So these are really very, very fragile patients. And what you might not know is that the patients usually on average gain weight when they are on the LVAD, and LVAD is only thought to be a bridge, of course, to heart transplantation. And you see here listed all the complications of the LVAD. So the goal is, of course, that these patients are listed for heart transplantation and finally undergo heart transplantation. So now I was talking about obesity and so to say, to the challenge to treat obesity before transplant. The idea behind is to improve the access to heart transplantation and also to facilitate an easier heart transplantation. The same is, of course, true for liver transplantation, kidney transplantation, but what is in the context of a heart transplantation and metabolic surgery after transplantation? Because this, of course, potentially also affects the outcome of the heart transplant. And there are some good data that this also is very beneficial for the transplanted heart. What else do we find in the literature besides metabolic bariatric surgery and on the edge to conservative treatment, balloons? Very brave. You see 2 patients on the LVAD under full anticoagulation, which is of course a relative contraindication for a balloon because you have a higher risk of mucosal bleeding. But you see it is sufficient. They lose weight, but after transplantation and balloon removal, you see what we all know. The weight returns back. So this is, of course, not an ongoing solution, but you can think, of course, about it. Maybe in the future, due to the perioperative morbidity by metabolic surgery in these fragile patients, we might use anti-obesity medication, and after the transplantation, where there is a plateauing or even a weight regain with anti-obesity medication, we can think about metabolic bariatric surgery with a reduced risk. Saying that, what is the risk in patients who have undergone any transplantation before? And these are data you see from the Ambesquip analysis. 336 transplant patients were compared with a big number without transplant. And to make the long story short, transplanted patients, when they undergo metabolic surgery later, have a higher risk of leak, maybe due to the immunosuppression. They have a longer operating time, and an increased length of stay. Of course, they are more fragile, more sick patients, so higher morbidity, but comparable mortality. No lecture without a review of the literature or meta-analysis. You see here a systematic review for metabolic surgery is a bridge to heart transplantation. This is already one of the take-home messages. 11 studies with 98 patients. BMI drop once more, somewhere between 10 and 14 BMI points. Here, 11 BMI points. Mean time between surgery and transplantation, 14 months. 71% are listed. More than half of the listed underwent transplantation. Mortality 0, but significant morbidity with 28%. So metabolic surgery, again, is effective and safe. We do see some morbidity. The mortality seems comparable. So what are my conclusions? Conclusion number 1, metabolic surgery broadens the access to heart transplantation by lowering the BMI thresholds. And metabolic surgery in patients with low left ventricular ejection fractions and LVAD should, of course, only done in centers that also have a high experience on one hand. On the other hand, there must be a cardiac surgical department or a heart transplant unit. The highest perioperative risk we see in patients on LVAD is bleeding, because they are, of course, fully anticoagulated, and there is always a balance between bleeding and the risk of thromboembolism, especially in these patients. And what I could also have shown you is that MBS improves also the organ function after the transplantation. I should also talk about perspectives. In my hospital, often the transplant surgeons, either kidney, liver, or heart, are not aware about the effects of metabolic bariatric surgery, so we need to come closer together. This is a call for closer collaboration between metabolic surgeons and cardiac surgeons in this perspective. Second perspective, weight loss before transplantation is desirable. I showed you specifically data about metabolic surgery, word of caution, bleeding, and morbidity. So future outlook, I'm convinced that anti-obesity medication will play a more important role in this setting, but post-operatively, I'm convinced that metabolic surgery still will play an important role. Fighting obesity in the context of solid organ transplantation. Vienna, 2nd to 4th of May, save the date, and Melbourne, 3rd to 7th September 2024. Thank you very much for your attention.
Thank you very much, Professor Prager. We have time for one question.
I saved 25 seconds.
So I have a question for you, Gerhard. And the question is about procedure selection. So you've mentioned that the morbidity is high. So rather than saying metabolic and bariatric surgery for these high-risk patients, should we specifically say sleeve gastrectomy? Because we know the risk differentially is not the same. So rather than speaking about all surgeries, because I've seen literature of gastric bypass done before transplant, should we specifically say sleeve gastrectomy?
Abdel Rahman, this is of course a nasty and very good question. You're totally right. The majority of procedures in the literature are sleeve gastrectomy, and considering that the leak rate is higher and the morbidity is higher, we should go for maybe the most simplest operation, and I personally would prefer sleeve gastrectomy. And saying that, you have seen the percentage of sleeves in my entire work is around 15%. But in this setting, yes, I personally think there are good reasons and arguments to prefer sleeve over bypass.
Thank you very much. So we'll move on. Next, it's my pleasure and privilege to introduce Professor Raul Rosenthal, who needs no introduction. He's the past president of ASMBS, the editor-in-chief of SWORD, and he's going to speak to us about metabolic and bariatric surgery and kidney function. Can we prevent end-stage renal disease? Raul.
Yeah, thank you very much. If you can put my first slide up. In 1993, when I came to this country, bariatric surgery was not on my agenda. And I started doing research at Cedars-Sinai in intra-abdominal, intracranial pressure and hemodynamics. So it's been 30 years. And besides a lot of publications and evidence, I'm going to show you in a few, We just got bestowed the Halverson Award at the American Society of Metabolic and Bariatric Surgery, showing the effects of intra-abdominal pressure on kidney function. And I'm talking to an audience of surgeons, and I'm sure through medical school you all learned about the abdominal compartment syndrome. When the patient's belly gets up, the kidneys stop functioning. And there are a lot of theories out there. Well, the problem is not in the belly. The problem is in the brain. And I'm going to show you that in a second. So we know about, these are my disclosures that don't pertain to this presentation. We know very well that chronic kidney disease is a problem. 1 in 7 adults in America have chronic kidney disease, which are responsible for $120 billion in expenses, one of the top 10 causes of death. But what's more staggering is that 90% of those don't even know that they have chronic kidney disease. The reason and risk factors of chronic kidney disease are obviously diabetes and hypertension, as we will know, but obesity is a serious risk factor as well. So does bariatric surgery play a role here? Well, the answer is yes, it does, and it is significant. And in the interest of time, since we're running behind, I'm not going to go over every single detail, but probably the Swedish study is a very cute small one that shows you that for those who are overweight that do not have bariatric surgery and rapid weight loss, the likelihood of developing chronic kidney disease is much higher. This is the bariatric group. This is the non-bariatric group. So bariatric surgery seems to decrease chronic kidney disease. This is a systematic review and meta-analysis published by Zhang. 32 observational studies, 32 were included in this meta-analysis, showing that there is a significant reduction in hyperfiltration and albuminuria in patients that have bariatric surgery and rapid weight loss. And Dr. Cohen, I'm sure, is going to talk to you in a few, but Ricardo published in JAMA Surgery in 2020 a very nice study comparing medical treatment versus surgical treatment of obesity and chronic kidney disease, showing very clearly that if you do surgery, the likelihood of having your chronic kidney disease go into remission is 80%, versus if you don't, it's 40%. And Ricardo is going to take it from here. Well, I've been publishing now for decades on intra-abdominal, intracranial pressure, and for the last 7-8 years, we've been publishing extensively on chronic kidney disease, how metabolic surgery has an impact in the chronic increased abdominal pressure. And this is a paper we presented at the American Surgical Association, the most prestigious forum we can have in America. We published it in the Annals of Surgery. And the baseline chronic kidney disease was based on the Kidney Disease Outcomes and Quality Initiative, which is the Bible if you want to publish and talk about chronic kidney disease. So we published this in Annals. Otherwise, I would have published it in SWORD because it's our journal. But when you present at ASA, you have to go to Annals. You have no choice. So we look at urine albumin-creatinine ratio and glomerular injury, and we showed very clearly at 5 years, looking at pre-op in chronic kidney disease, urine albumin-creatinine ratio, how at 5 years there was an 82% difference. And you can see here in the first line, I don't know if you can see it, at 1 year and at 5 years, how you have a significant decrease in the chronic kidney disease staging and the urine albumin-creatinine ratio. Rapid weight loss surgery helps. And then we went ahead and showed also how there is a decrease in the prevalence of chronic kidney disease. This we published again and presented, showing very clearly in stage 3, because what we don't know, and we talk about obesity and diabetes and obesity and cancer and obesity and kidney disease, we don't know when it's going to be irreversible. And that's why the guidelines need to be updated today, because it is not just the BMI and the comorbidity, it's when obesity starts that we need to care about. Here you can see in surgical cases compared versus controls how there is a significant decrease in the staging. So what we are working now? We're working on the chronic intra-abdominal pressure or chronic compartment syndrome. And we did a two-stages publication in the Journal of Surgery, trying to demonstrate a different theory about the increased intra-abdominal pressure being the reason, about the increased urethral pressure being the reason, because, you know, if your intra-abdominal pressure goes above 15, you stop making urine. And they say, well, because you shut down the renal arteries. Well, if the mean arterial blood pressure is 60, 40, how can you shut down the renal arteries with a pressure of 15? Something else is shutting down the blood flow to your kidneys. So the problem is not in the belly, it's in the brain. And we did a lot of publications, and we showed very clearly in the laparoscopic model, as you can see here, at intra-abdominal pressure of 0, when you create pneumoperitoneum, there is a dramatic increase in vasopressin. You cannot measure it anymore. And this is cheap. You can do it in your own lab at home. So you can do a lot of research on this. In heart failure, patients on PEEP, on events, on ileus, just do it because it works. And you're going to be here presenting. And if you add PEEP, vasopressin goes even higher. And when you take away the PEEP, everything goes away. But see what happens with the optic nerve sheet, because that's how you measure intracranial pressure in 2023, with the optic nerve sheet. As you increase intra-abdominal pressure, the optic nerve sheet goes up, and so does the vasopressin level. So we described a mechanical mechanism that, in the interest of time, I'm not going to present here today since we're running behind, but the chemical is the diaphragm going up, the intrathoracic pressure going up, decreased drainage of blood from the central nervous system. Monro-Cayley hypothesis, there is a decreased blood flow and hypoxia, and to prevent that, boom, the Cushing reflex. Vasopressin brings all the blood back. And then the chemical effect, which is triggered mainly by compression of the lower lobes of the lungs. In the chronic model, in the obese patient that comes to your office, that tells you that has pseudotumor cerebri. Where is the pseudotumor cerebri coming from? And this is the paper. I mean, there is data now showing the chronic intra-abdominal compartment syndrome. This is copeptin studies published in Europe. Copeptin is a metabolite, a chronic metabolite of vasopressin. 3 large European trials showing increased copeptin. And this is what we presented at ASMBS, showing that the patient that is obese and doesn't have bariatric surgery and has chronic kidney disease has decreased renal blood flow compared to the patient that has bariatric surgery, rapid weight loss, and how you increase renal blood flow. And that's why we got the Halverson Award. How do you measure renal blood flow? You measure it looking at urine albumin creatinine ratio, as you can see here. Less than 20 is normal, more than 20 is decreased. And we can go into details later, but you can see stage 2 and stage 3. BUN creatinine ratio before surgery and after surgery significantly increased, which means that you're increasing the renal blood flow, you're improving and decreasing the hyperfiltration rate, as you can see here, at all stages, pre-op and post-op. You can see how the renal blood flow increased and how the BUN creatinine ratio decreased, and so did the hyperfiltration. So in summary, I can say that there is improvement in kidney function with bariatric surgery. Chronic kidney disease, it's a very silent but prevalent disease. We believe that there is a chronic abdominal compartment syndrome, and we should be looking at the copeptin and vasopressin axis as a reason for chronic kidney disease in this patient population. And that concludes my presentation. Thank you very much.
Well, thank you. And then we come to the last presentation, which is from Professor Cohen from Brazil. He's the incoming president of the Ifso. So welcome to Naples. And the presentation is metabolic bariatric surgery and kidney transplantation, timing, outcome, and results.
Thank you. Thank you for inviting me here. I'm going to speak about the timing for metabolic surgery and kidney transplantation and avoid Nimeri's question. I'm going to try to answer if sleeve or bypass are good options or not. Where am I disclosing? Well, I have some disclosures. Basically, I'm going to show research funded by J&J MedTech. So I'm going to cover the safety and efficacy of metabolic surgery before and after kidney transplantation. And what's the problem here to put you in the same page that I am with kidney problems? You see here that obesity puts a high risk of graft loss in patients that receive a transplanted kidney. And BMI, it's very interesting. In all the endpoints analyzed here in this systematic review and meta-analysis, higher BMIs carry more mortality, decreased patient survival at 3 years and a decreased graft survival at 3 years. So all of these favors lower BMIs when patients are receiving a kidney. And obesity is the third leading cause in the US for not being listed for transplant. I just happened to know yesterday that in Brazil it's the second reason. And 1 unit down of BMI increases 9 to 11% the chance of a kidney transplantation. What's the safety and efficacy of metabolic surgery before kidney transplantation? So it can be a bridge to kidney transplantation. It's there, absolutely no doubt. Why? Look at this very interesting graph. When patients receive bariatric surgery, look at the right side of the screen, the number of people transplanted increase sharply. So weight loss is very effective to put people back in the transplant list. What do data tell us? There's, we all know, significant weight loss. It increases the transplant eligibility. It controls comorbidities, type 2 diabetes, hypertension, dyslipidemia. It has a slightly higher complication rate and mortality when compared to people that undergo metabolic surgery without end-stage kidney disease. There are several papers published, mostly not robust scientific evidence, mostly retrospective or small prospective studies that shows that metabolic surgery can be a good bridge to kidney transplantation. This is a very interesting systematic review. Although there's significant heterogeneity between the studies, again, all those papers, they report a slightly higher complications rate when compared to people without end-stage kidney disease, and the dependence on dialysis should not be a contraindication for surgery because it's not an independent factor for 30-day morbidity after surgery. If you look again at the MBSA equipped data, look at the 925 patients with end-stage kidney disease, so stages 4A, 4B, and 5. The overall complications in those patients is still low. End-stage kidney disease mortality after metabolic surgery, it's comparable to patients with end-stage kidney disease that do not undergo surgery. And again, end-stage chronic kidney disease should not be a contraindication for surgery. What's the safety and efficacy of metabolic surgery after kidney transplantation? Again, what's the problem? The problem is that kidney transplant recipients with immunosuppressants, with corticosteroids, they gain an average 10 kilograms during the first year after transplantation. And obesity, of course, may affect the graft, may affect the adverse events on the cardiovascular system, wound healing, life expectancy, when compared to leaner patients that received a kidney. Again, a lot of papers. For the sake of time, I'll go directly to the conclusions that based on that evidence, those are the only 4 papers that are significant data, although not level 1 or 2 evidence, the 3 or 4, but they guide us that metabolic surgery after kidney transplantation gives a substantial decrease in BMI without major complications. The risk of death and graft loss were lower in the group of bariatric surgery, although a very short follow-up, an average of 24 months. There's limited evidence, robust evidence of the advantage of surgery after kidney transplantation, and there's no long-term data on the graft function. So it's a huge avenue to be studied. What about the immunosuppressants pharmacokinetics? If you compare the sleeve and the bypass, surprisingly, there's no difference in tacrolimus dose. Tacrolimus is the most commonly used long-term immunosuppressant. So if you look at the gastric bypass and the sleeve gastrectomy, there's no significant difference in doses. And that was repeated in another study published a year ago in obesity surgery. Again, sleeve and bypass regarding immunosuppressants, there's no difference. And there's some indirect comparisons on which is the best procedure. And again, that's surprising, although again, it's not scientifically robust, it's level 3 and 4 evidence. But if you look at the papers that use the sleeve gastrectomy as the main operation after and before a kidney transplantation, and the gastric bypass, again, the same, all other papers listed here, if you compare them, remember, it's an indirect comparison. So weight loss is reported different between the papers. So in both operations, there's a significant weight reduction. In both operations, there's a significant weight loss that enable the patients to be listed for transplantation. There's a lower incidence in both operations of hypertension, diabetes, and all that comes with metabolic diseases. There's a reduced or 60% reduction on graft failures in 2 retrospective studies. However, in the gastric bypass and the sleeve, there's scarce reported outcomes on delayed graft function and readmission for renal dysfunction long term. We don't have the data. Mortality and complications are surprisingly the same in all the studies that I brought here. But in the gastric bypass, you should be aware of oxaluria nephropathy. That's a problem that we need to screen. We have a pretty high, significant number of patients with end-stage kidney disease. We're running a trial of end-stage kidney disease and metabolic surgery. And the way you can screen this is the urinary magnesium levels. This is the first hint of oxaluria. If you had this, the patient can lose the graft. So this is the drawback of the gastric bypass, that the sleeve has no report of this complication. And this is a very interesting, as we don't have randomized control trials so far in kidney transplantation and surgery, this is a Markov decision analytic model. It's a model, in summary, that predicts complications of chronic diseases. So they took into account weight loss, the probability of transplantations, the risk of dialysis, and surgical mortality. It's interesting. In this, it's a statistical model. Roux-en-Y gastric bypass is more effective therapy for those patients with end-stage kidney disease, giving them access to transplant and thereby improving long-term survival. So this is a Markov model. Ali here, sitting here, showed in one of his papers in 2021 that in patients that didn't have baseline chronic kidney disease, sleeve gastrectomy and bypass long-term, the bypass patient had less patients with nephropathies as a follow-up. So the gastric bypass is more effective in preventing the progression to chronic kidney disease when compared to the sleeve. What's the best timing? That's another question that has very questionable answers. This is a study published at Raul's journal about a month ago. And it's interesting that it's a propensity score matched analysis on surgery before or after kidney transplantation. So there's no statistical difference. There are benefits before and after the kidney transplantation. And this is the 5 years follow-up that we published about almost 1 year ago that Raul showed the 2 years follow-up. We compare gastric bypass versus the best medical treatment with GLP-1 receptor analogs and SGLT2 inhibitors. We show that we can decrease in 63% of the progression of chronic kidney disease with the gastric bypass. In summary, surgery in patients with end-stage kidney disease are reasonably safe. They lead sleeve and bypass to significant weight loss and control of comorbidities. Immunosuppressants are not an issue in both techniques. May be performed before or after kidney transplantation. Still, we don't have level 1 evidence on the better operation, but in a statistical model, it seems that the gastric bypass is a good option. However, we should screen for oxaluria. That's a problem again. Metabolic surgery actually should be done before the progression of chronic kidney disease, because this session wouldn't be in place here if we could have early access of patients to the study, to operations. Raul, we're doing a randomized control trial right now of end-stage kidney disease versus the best medical treatment, semaglutide and SGLT2 inhibitors and the gastric bypass. And we're measuring the real glomerular filtration rate, the real one, not the estimated. It's very interesting. For the first 3 to 4 months, TFG decreases after a gastric bypass. And we get mad because it's a trial. But afterwards, it improves much better than the combination of GLP-1, of semaglutide, and empagliflozin. So maybe probably in 2 Ifsos, I'll be here presenting our data of the end-stage kidney disease. Thank you very much.
Thank you very much. 2 great talks, open for discussion. We have a few minutes time, 3 minutes. Ali?
Can you activate the mic, please?
No.
We need the mic in the middle.
Maybe come here, Ali. It's easier. In the meantime, one question. My nephrologists tell me they don't want to refer patients on chronic dialysis because this is one of the few situations where the obesity paradoxon is true. So an increased life expectancy for obese patients. Would you comment on that? What can I tell them to refer patients?
Oh, Gerhard, you can tell them there's strong literature, although it's not very robust 1 and 2 evidence so far. We're producing the level 1 evidence right now. But obesity improves the glomerular filtration rate, improves the access to transplant, and they don't know how long it will take to be stage 5 for transplantation. So they should be aware of surgery. You mentioned this. Nephrologists, cardiologists, they don't know about surgery. They think it's something from another world, so from another planet.
Okay. Yeah, Ricardo.
Yeah.
Thanks for presentation. You briefly touched about the oxaluria, and I wanted to share this sad story of my patient with all the audience here. It really breaks my heart. So a nephrologist referred a patient with the end-stage kidney disease to me 8 years ago to undergo bariatric surgery to make her eligible for kidney transplant. And she had severe reflux disease, so we decided to do the gastric bypass, and we did. And patient diabetes went into the remission. Patient lost a lot of weight and made her eligible to get the gastric bypass, to get the kidney. She received the kidney, she was off dialysis for 3 years, and then she started developing oxaluria, severe oxaluria, that nephrologists couldn't manage that, and that damaged the kidney. So she lost her kidney, she went back onto dialysis for 2-3 years, and then they referred patient back to me to reverse the bypass, and that was really, really sad story. So I had to reverse the bypass. I did that with the hope that that can reverse the oxaluria, then that make her eligible for second kidney transplant. And that happened, and they retransplanted, and hopefully so far she is okay. But for all the audience here, if we do the gastric bypass in patients with kidney disease that are on the line to get the transplant, please be aware of the oxaluria that can damage the kidney and ruin the patient's life, and you're going to be sad for years to come.
Thank you. I think very last question, very brief.
Raul, quick.
Yeah, thank you. Congratulations, Dr. Angrisani, for a wonderful Congress. Thank you very much. Give him a round of applause. And Gerhard, the question is for you. The LVAD, we have the same experience as you presented with bleeding. Mm-hmm. We started in the United States, and I'm running the registry for Abiomed with the Impella device, which is a removable device. We put the Impella, we do surgery with Impella, we do a sleeve, we get out, and 2 days later you remove the Impella, and you don't need to anticoagulate the patient. Are you doing Impella in Europe, or is it just in the United States? Because that would be the solution to the LVAD.
I'm not aware of that. Those patients were referred by the cardiac surgeons, and they were for a long time already on the LVAD. Some of them for 5 or 6 years.
Exactly.
And this is the real problem, because they don't expect the transplantation. They die on the complications on the LVAD. This is my experience. So the metabolic surgery in that context is their only chance. So I can't answer you the question.
Look for the Impella.
Yeah,
that's the
I'll
solution.
do that.
Well, thank you very much. This was a very exciting session, very well attended, and thank you all the attendees and the brilliant speakers.
Thank you very much.